Hi, this is Brian Kim. I want to share with you this case of a patient who is a teenager and has a cataract. He has retinitis pigmentosa and has high myopia, pathological myopia, minus 28 diopter lens. And so you can see in these teenage cataracts, also with retinitis pigmentosa, you can have weak zonules. And so you'll see a little bit of a challenging capsulorhexis. You'll be able to see and appreciate the zonular laxity in this case as we take this cataract out. So I use a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size my rhexis. It's my paracentesis incision, first on the right side and the left side. Make sure the incision is flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then intracameral epinephrine. And this is intracameral trypan blue. I meant to put a bubble in there first, but the bubble didn't go in, and so I'm going to quickly irrigate the trypan blue out. And this is some dispersive viscoelastic to coat the corneal endothelium and push down on the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel into the corneal stroma, and then when I'm ready, I enter. I push some more viscoelastic in to fill the chamber. And this is going to be the cystotome, again, because this patient has ROP, probably weak zonules, and also this is a young patient, and the capsules tend to be very elastic. I want to start with the cystotome first. The capsules with these patients tends to run out. And so the key is you want to continue to pull inward as you do the rhexis, because if you try to do it the normal way, it's going to spiral outward. So as I make the rhexis, I'm pulling more centrally than I would. With the teeth closed, I'm just repositioning the flap, and then I'm going around, making sure I'm pulling more towards the center as I make the rhexis. Like right here, pulling more towards the center, more towards the center, and then finishing it off. Burp the viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down, and then I get a nice wave here. Try to decompress, but the lens is very soft. Irrigate the surface of the eye, adjusting the sleeve, lifting the incision, going in with irrigation off to minimize Descemet's trauma. Again, this is a very soft lens, so you just have to be mindful that the whole lens doesn't just come up. So you want to modulate your foot with the vacuum, making sure you protect the bag with the chopper, and that was it. That was pretty quick. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I start subincisionally removing the cortical material from anterior to posterior. Polish underneath the rhexis edge. removing the lens epithelial cells, pulsing VSS into the subincisional capsular fornix, which was clean here, and then pushing cohesive viscoelastic to fill the bag, and then using the sweep to polish underneath the rhexis edge. First on the left side, and then on the right side. This is a single piece acrylic intraocular lens. I'm injecting it into the capsular bag. You can tell this lens is very thin. It's a low-powered lens. Go in with the INA handpiece, activate irrigation, making sure both haptics disengage off the optic, go underneath the optic, tilting it and rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag. Repositing the lens into the bag. Making sure I clean the posterior capsule completely. Polishing under the rhexis edge. I end up getting a little compulsive with the cleaning at the end of the case here. Removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a young patient with a cataract, history of ROP, pathological myopia, -28 diopter, refraction. You can see the elasticity of the capsule during the rhexis. It's important to pull towards the center in these cases because there's a significant outward force as the capsule wants to go radial in these cases. So by pulling more centrally, you're able to control the rhexis a little bit easier in these cases where there is an elastic capsule and weak zonules. So I hope this was helpful to you, and I thank you for your attention.